Well, today we're going to finish up our discussion of arrhythmias. And last time we talked about the atrial arrhythmias and the junctional arrhythmias. And today we'll be speaking a little bit about ventricular arrhythmias. And what I'm talking about is the differential diagnosis, really, of a wide QRS on the electrocardiogram. Now, when we all look at this, we might right away just think that this looks very much like ventricular tachycardia. But that's the question. Is it really ventricular tachycardia? What else might it be? It may not necessarily be ventricular tachycardia. Right? One possibility certainly is ventricular tach, but another one is supraventricular tachycardia, with a wide QRS complex. Now, what will give you a wide QRS complex and have a supraventricular rhythm? Bundle branch block certainly will do it. Well, we'll just go down our routine, right? If the initial part of the QRS is prolonged, we think of what? We think of Wolff-Parkinson-White. If the whole QRS is prolonged, we think of intraventricular block. If the terminal portion of the QRS is prolonged, we think of, as you said, bundle branch block. And also a form of rate-related bundle branch block, or as occasionally it's not necessarily related to the rate, but is aberrancy. I'm not sure I spelled that right, but it's something like that. Okay, so you can have a supraventricular tachycardia with any of these four things, and you could wind up with an EKG, which will appear very much like a ventricular tachycardia. So the question is, how do you differentiate ventricular tachycardia from supraventricular tachycardia? And this can be a very difficult and pressing problem. Now, certainly, if the patient's in terrible shape, has no blood pressure, you don't want to waste a lot of time doing different things to differentiate the two, because he has to be treated immediately. So, of course, you would shock him right away if the patient was doing very poorly. Okay, the question comes up when the patient is doing reasonably well. Then it becomes important to differentiate these two. All right, now, well, there's one sign, a clinical sign, which is somewhat helpful, but not a 100% situation. And that is the clinical appearance of the patient. We'll make up a little table here. We'll call this supraventricular tach and ventricular tach here. Number one would be symptoms. Now, if the patient is severely symptomatic, hypotension, comatose, or non-responsive, you think that this is more likely a ventricular tach. And if the patient is relatively asymptomatic, has relatively few symptoms, then you think that this may be a supraventricular tachycardia. This is just a general rule, and certainly by no means absolute, because you can have young patients who can tolerate a ventricular tach quite well. On the other hand, you can have old patients who tolerate a supraventricular tachycardia poorly. So there's a lot of exceptions to the rule, but it's something else to keep in your mind when you're considering the situation. Okay, another thing. What might be another thing that you could do to differentiate these two? Carotid sinus pressure, right? Carotid sinus pressure, CSP. Okay, now if you have a response to carotid sinus pressure, this means you're dealing with which one? If you have a transient slowing of this ventricular rate, that means you're dealing with a supraventricular tachycardia. So here you have a response. And here you have no response. Okay, but just because you have no response, that does not mean you do not have a supraventricular tachycardia. In other words, this is only a helpful thing if you actually get a response. Right? Because as you all know, in patients with PAT, Some of them respond to carotid sinus pressure and some of them don't. So this is helpful if you do see a response. Now, a third thing, what else can you do? Well, as we indicated before, when you're looking at supraventricular arrhythmias, you certainly want to look at the P-wave situation in ventricular arrhythmias. You want to see the relationship of the P-waves to the QRS complex. So you go through the usual maneuver and looking for P-waves that we described previously. And just to review those, the first thing you do is you take a full electrocardiogram and you look at every lead, because in some lead that you might least suspect it in, you might see very nice P-waves. Right? Now, generally the best leads, as we said, are leads 2 and V1. They're generally the most satisfactory leads. If this doesn't work, then we can try looking at some other things like Lewis leads, as we mentioned, CF leads, if we can do that on the particular electrocardiogram. And then finally, we can go to such things as esophageal leads and to eventually an atrial wire in order to see the relationship of the P waves to the QRS. So let's say that we find P waves in the electrocardiogram and can ascertain their relationship to the QRS complex. Right? Okay, now, if the ventricular rate is greater than the atrial rate, what are we dealing with, most likely? Right. It's AV dissociation, and in this case, it would be what? Most likely a ventricular tachycardia. It could be something really obscure like nodal with aberrancy or nodal with bundle branch block. You know, this doesn't rule that out. But as a general rule, though, if the ventricular rate is greater than the atrial rate, you're probably dealing with a ventricular tach. And the other way around, if the atrial rate is equal or greater than the ventricular rate, then you're probably dealing with a supraventricular tachycardia. So the relationship of the P waves, if you can find them, to the QRS can be very helpful in differentiating these two. Okay?
Do you have to see a capture beat?
Okay, that's the fourth thing that you can look for in the electrocardiogram, is the presence of capture beats. Okay, capture beats can also be helpful. And when you see a capture beat, what does that mean that you have?
Some conduction is occurring, and so you have AV dissociation.
It means AV dissociation, again. And again, AV dissociation, when you're trying to differentiate these two, generally means ventricular tachycardia in this setting. Okay, so if you see capture beats, that means the presence of capture beats implies ventricular tachycardia. And what a capture beat or a fusion beat, this goes for fusion as well, what you might see in the electrocardiogram is something that looks like this. You're going along with your rapid rate. Here, draw this too long. And then a little earlier than you'd expect the next beat to come, the next beat should be here, you'll see a normal appearing QRS complex. And then you'll see a reappearance of your wide QRS complex. This would be a capture beat. Something in between this, where it's not quite as broad as the basic complex, but this might represent a fusion beat, where you have simultaneous depolarization taking place by a normal pathway from above and from the ectopic ventricular focus from below. It'd be a fusion of those two. You get a QRS complex that might look something like that. Okay, so these are 4 guidelines that can help you. And as I said in the beginning, if the patient's doing very poorly, this is sort of an academic exercise. And actually, you're doing the patient a disservice to go through a routine to try to differentiate. I mean, you just as well put the paddles on and shock them right away. Certainly, if it is ventricular tachycardia, you want to move very quickly and cardiovert him, because the rhythm may degenerate into ventricular fibrillation. If you have time, and we very frequently see this, the patient's doing quite well, then you can go through these various measures to differentiate. This can be a very difficult problem, and you have to use your clinical judgment and all the facts that are available to you to make to differentiate them. Okay.
Random, or do they occur if you had a long enough strip, would they occur in a regular pattern?
Mm-hmm. Some patients with ventricular tachycardia may never have capture beats. And most of the ones that I have seen are really just random things. They just come in. Occasionally you'll see a patient with a fairly regular intermittent capture. I think that it varies.
Yeah. You know, the thought if you have a regular atrial rate and a regular ventricular rate, which are different, and mathematically you should expect an atrial beat to come down after the refractory period to the ventricles on a regular basis, assuming conduction is normal.
Right. When you have something like a nodal rhythm with an AV dissociation, with your nodal rate going at 80 and your and your atrial rate going a little bit slower than that, then you may see your capture beats occurring at very regular intervals. But at these rapid rates, rapid ventricular rates, it's unusual, though possible, that you may see regular capture or fusion. One of the problems is the reason is that the ventricular tachycardia itself is not perfectly regular. Ventricular tachycardia is not perfectly regular. And some people use that as a differentiating point between supraventricular tachycardia and ventricular tachycardia. But you can try to use it, but I've frankly found that this is not too helpful. In a practical situation, I haven't found that to be much use. People are always bringing it up, and we're always seeing exceptions. Okay, so that's a little bit on ventricular arrhythmias. We just mentioned ventricular tachycardia. Of course, there are other forms of ventricular arrhythmias, such as ventricular premature beats. I think you all know how to recognize them. When they're premature ventricular beats, as we talked about, and there are ventricular escape beats. We mentioned these in the introduction to our discussion of arrhythmias. And we have your ventricular tachycardia, and then you can have ventricular fibrillation. All right, well, let's talk now a little bit about disturbances of repolarization. Okay. And here, the most important ion, when we talk about disturbances of repolarization, we're really talking about the effects of certain drugs and certain ions on the electrocardiogram. Okay? And by far, the most important ion that we're concerned with is potassium, high and low potassium. They are affected electrocardiogram. Less important, but also worth discussing, certainly, is the effect of calcium. Other drugs that you should know about and their effect on the electrocardiogram are quinidine, and pronestal. And these act quite similarly what they do to the EKG. Okay, well, let's first talk about low, high. And we'll say first here, we'll talk about calcium. Okay, what is the effect of low calcium on the electrocardiogram? These drugs, I should add at this point, and electrolytes generally produce disturbances of repolarization, which means they affect the QT interval and the ST segment and the T wave.
QT prolongation.
Okay, so with hypocalcemia, you get QT prolongation. Looks like this. With hypercalcemia, you get what?
Shortening.
You get just the opposite. You get shortening in the QT interval. All right. Now let's take a look at potassium. Okay, low potassium gives you what?
So prolonged QT interval.
Right, also a prolonged QT interval. But here, you have a somewhat different appearance that you do with potassium. You get sort of a flat, long T wave with a U wave following it. So the QT interval is prolonged in both hypocalcemia and hypokalemia. But the difference is that in low calcium, what you're supposed to get is a prolongation of the ST segment, whereas in hypokalemia, you get a prolongation of the TU wave. It's the TU wave, which is prolonged in hypokalemia. Okay, I consider it very important to be able to pick up this on the electrocardiogram. Okay, this is quite sensitive and should lead you to some definitive therapy, which in some cases can save someone's life. I think that the recognition of hypokalemia is extremely important. Okay, now the effects of quinidine and pronestal look very much like the effects of potassium. So anyone that's taking these two drugs, you really can't, you would have a lot of difficulty in saying whether they do or do not also have hypokalemia. So these two drugs here, this is the effect of this drug. So anybody on a standard maintenance dose of this drug will frequently have the appearance of hypokalemia on the electrocardiogram. Okay, what's the effect of quinidine and pronestal toxicity? We talked about this earlier. See if we can review that point. What do you see with quinidine and pronestal toxicity?
Prolonged QRS.
Right, prolongation of the QRS duration, or intraventricular block. So this is quinidine pronestal effect, whereas quinidine toxicity, or pronestal toxicity, you wind up with prolongation of the QRS, or intraventricular block. QRS just spreads out. Okay, now let's just go over hyperkalemia, because that does different things to the electrocardiogram. It doesn't shorten the QT interval. Okay. So normally your potassium is somewhere about 3.5 to 5.5. You have an EKG that looks like this. Right. Now when the potassium goes above 6, in the range of 6 to 7, what is the first thing that you see in the electrocardiogram that reflects hyperkalemia? Right. Right. You get T wave peaking. You get an appearance that looks something like this. A little exaggerated, but sometimes they do look like that. You get tenting of the T wave. Okay, so this is a relatively early sign of hyperkalemia on the electrocardiogram. And then as the potassium goes up, the P wave will diminish in amplitude, although the P waves will still be atrial contraction, but you'll lose the amplitude of the P wave. It may look like you're dealing with a nodal rhythm. And the T wave will still remain peaked. And then finally, when you get up in the range of 7 to 8, what do you see in the electrocardiogram? Broadening of the QRS, or intraventricular block, again, as we pointed out. And when you see intraventricular block, again, you've lost your P wave very frequently, even though you have still atrial contraction. You'll wind up with a wide QRS, and you may get a secondary T wave change, so you might lose your T wave peaking. Okay, now the important things to recognize, well, let me just finish this up. When you get up around 9 to 10, eventually you wind up with agonal EKG or a sine wave. Just look like a sine wave, and then they fibrillate. But the most common way that we see patients presenting with hyperkalemia is like this, with T wave peaking, and like this. And there are many patients now, I can think of at least 3 so far this year, that we've seen that presented like this, looking like complete heart block with an idioventricular rhythm. So anytime you see that situation, you should think, especially with no prior history of heart block or a patient who's recently been in normal sinus rhythm, just think to yourself, I wonder if this patient doesn't have hyperkalemia, and try to anticipate the possibility. That's the other differentiating point, is that in this type of situation, the rate is usually normal. whereas in complete heart block with idioventricular rhythm, the rate is usually fairly slow, 40, 50, or 30. And the ischemia is like this, with T-wave peaking, and like this. And there are many patients now, I can think of at least 3 so far this year, that we've seen that presented like this, looking like complete heart block with an idioventricular rhythm. So anytime you see that situation, you should think, especially with no prior history of heart block or a patient that's previously been in normal sinus rhythm, just think to yourself, I wonder if this patient doesn't have hyperkalemia, and try to anticipate the possibility. That's the other differentiating point, is that in this type of situation, the rate is usually normal, whereas in complete heart block with idioventricular rhythm, the rate is usually fairly slow, 40, 50, or 30 in the complete heart block range. Whereas in this situation, it looks like complete heart block with idioventricular rhythm, except the rate is surprisingly normal. It may be slow around 60 as well, though, but it's generally faster than the complete heart block range. So that may be a tip-off. So, but the important thing to remember is the 2 ways that these patients present clinically are, one is the T-wave peaking, and the other is the intraventricular block, or the wide QRS complex. The last thing I think we want to cover in this course is a routine for going over the electrocardiogram. And I think it's really important to develop this routine because otherwise you just miss things. And certainly in the beginning, it's very viable to be able to follow a particular pattern. As a student, when they're learning electrocardiograms, very often you'll see someone just go through a tracing and they look at it and they say, I don't know what's going on. That's the most common thing that I see. Whereas if they would just take the time and go through a routine that we're going to describe, things would automatically just pop out at them, and they would have a diagnosis. Also, other people have a tendency, they see an inferior MI, and then they throw the tracing away, and they forget about noticing the first-degree block and other things, which can be extremely important. So I think for many reasons it's important that we develop a routine. So the routine that I found helpful, suggest, is first thing you do is you look for the rate and the rhythm. Rate and rhythm. We all know how to determine heart rate by now. We'll talk about that. And if you're dealing with an arrhythmia, this is the time to get your calipers out and to decipher that arrhythmia. Okay? Next thing you might look at is the PR interval and the P wave. And here you'd pick up things like first-degree block, and you might suspect nodal rhythms or Wolff-Parkinson-White, just on the basis of too short a PR interval. Heart block on the basis of a PR interval that is prolonged. Okay, the P wave, look at the P wave and you decide whether the patient has right atrial, left atrial enlargement. Right? The next thing you look at is the QRS complex. If the QRS complex is less than 0.10 seconds, you can go on to the next step. Okay, if it's greater than 0.10 seconds, you should stop at this point and decide, why is the QRS prolonged? If it's between 0.10 and 0.12, you're dealing with an incomplete conduction disturbance. If it's greater than 0.12, you're dealing with a complete conduction disturbance. Okay, so then you look at your electrocardiogram and you say to yourself, which part of that QRS is prolonged? Is it the beginning? Is it the whole thing? Or is it the end, right? If it's the beginning, you're dealing with a WPW, most likely. If it's the whole thing, you're dealing with intraventricular block. If the terminal portion of the QRS is prolonged, you're probably dealing with a bundle branch block, though you may be dealing with a peri-infarction block. That's less common. By far the most common form of terminal conduction disturbance, though, is a bundle branch block. Okay. So then you look at V1 and V6. Maybe I should write this down. You look at the initial, the whole thing, or the terminal. Initial, whole, or terminal conduction disturbance. Decide which you're dealing with. Okay. And if you're dealing with a bundle branch block or terminal conduction disturbance, then you look at V1 and V6. as we described, and decide whether you're dealing with a right or a left bundle branch block. Right? Once you've decided that you're dealing with a right or a left bundle branch block, you go back to the frontal plane and you look at the axis. Right? And that'll tell you whether you're dealing with one of the hemi-blocks or a combined block. Right? Okay, so if you just go through this routine, QRS wide, initial, the whole thing, the terminal thing. If it's a terminal, look at V1 and V6. Decide whether you're dealing with a right bundle or a left bundle. Then look at your axis to see whether you're dealing with an anterior, posterior hemi-block or complicated block. Okay. Now, if you have a wide QRS complex, you have to be very careful about going on, because in the presence of a wide QRS complex, it is difficult to diagnose infarctions. In the presence of a right bundle branch block, you can diagnose infarctions. Right? In the presence of a left bundle, very difficult. It's also difficult to diagnose either right or left ventricular hypertrophy in the presence of a conduction disturbance. So you have to keep that in mind. If you reach this stage and you find that you have a wide QRS complex, you have limitations on whether you're going to be able to diagnose infarction or hypertrophy. But let's say our QRS complex was normal, and so we ask ourselves the next question: is there an infarct? And in order to decide whether the patient has an infarct or not, we look at the frontal plane, 1, 2, 3, AVR, LF, for significant Q waves. Right? It's all right to have a significant Q wave in AVR, right? But any other leads, you should not have a significant Q wave. We've defined significant Q wave. Okay? If there's no significant Q waves, you look at the horizontal plane and you look at the R wave progression. R wave progression should proceed in a smooth, normal fashion, as we previously described. Okay? If there are no evidences of an infarct based on the lack of Q waves or normal R wave progression, then you go on to the next step. But if you do see an infarct, you want to know two things about it, which are what? Location and age. Okay? Age and location. Okay, well, let's say there was no infarct, and we go on to the next step. And we ask ourselves, is there hypertrophy? And for hypertrophy, we go through our criteria we listed before, which are what? What are the criteria for hypertrophy?
Tall, hard.
Those include voltage, axis, intrinsicoid, and ST wave changes. Let's put that. Voltage, axis, intrinsicoid, and ST wave changes. Okay. And we went over all of these before in great detail, and the criteria for right and left ventricular hypertrophy, you follow the same outline: voltage, axis, intrinsicoid, ST wave changes. And then finally, in the last step, you look at the QT interval and T wave changes that you have not yet already covered, and decide whether there's drug, electrolyte problem or non-specific ST wave changes that you haven't already covered. Okay, so this is a 6-step routine, and as I said, we found this quite valuable in approaching the routine electrocardiogram.